the neuron has the shorter neurites at the top, and then one long neurite, which is we call the axon. And this axon is ensheathed by these myelinating Schwann cells, which form these insulin-like sheaths and help the signal to propagate down the axon. So when you take a cross section of one of these myelin sheaths surrounding an axon, you see the picture down at the bottom. You see that the myelinating Schwann cell wraps tightly around the axon, and PMP22 is localized to this compact myelin area. So we don't know what PMP22 does, and we don't really understand how having too much causes neuropathy. So answering these questions will create new opportunities for developing therapeutics. Additionally, we know that in all forms of demyelinating CMT, there is secondary axon degeneration as a consequence of the dysfunctional myelin. So identifying mechanisms that cause the axon degeneration and targeting those is also a viable strategy. Additionally, as I mentioned earlier, there's a lot of variability in patient symptoms. So people are looking for modifiers of the disease, so other molecules in the cell that potentially make the disease more severe or less severe in certain patients. So identifying those will also create new targets for identifying or creating therapeutics. And lastly, identifying biomarkers or readouts of disease severity. And these are both critical for diagnosis and also for clinical trials. And lastly, I wanted to give a brief clinical update. We're going to be hearing more about this later. But some of the ongoing studies for CMT1A are listed here. So there are several studies that are aimed at reducing PMP22 expression. The furthest in clinical trials is the PXT3003, which is a combination of 3 drugs that lead to reduced PMP22 expression. And there are also PMP22 antisense oligonucleotides and siRNA or shRNA strategies which directly reduce PMP22 expression levels. And the diagram on the right is a simple diagram of how the si and shRNA strategies work, where they complementarily will bind to the PMP22 mRNA, which is the intermediate between the DNA and the protein, which actually performs the functions in the cell. And so this will cause the mRNA to be degraded, whereas antisense oligonucleotides will bind and block some sort of regulatory function in the mRNA, lowering expression of PMP22. And lastly, there's also neurotropin-3, which is shown to improve Schwann cell viability. And I also meant to update this to include HDAC6, which also improves Schwann cell health. So there are several ongoing avenues that are being explored to treat CMT1A. And thank you, everyone. I'll be happy to take questions after David's talk.
I'll need a bit of assistance getting my brief talk loaded. Oh, I could go to the computer and try and work. I wonder what will happen if I go one more. But nothing happened. No, no. We just have to have a next talk, yeah, loaded. Yeah, it's a talk that's labeled CMT1B. So. There we go. Well, so I'm going to do a similar update about CMT1B. And I know this breakout session was titled CMT1B, but I'm not going to use that terminology, and I'll explain why. So I'm just going to call CMT1B rather under a broader title of CMT due to myelin P0, and I'll abbreviate that MPZ gene mutations. Part of the reason for using this title rather than CMT1B is there's a lot more variability with individuals who have CMT from MPZ mutations, and so CMT1B is just one part of neuropathy from myelin P0 mutations. So Dr. Moss went over some of this, but just to realize that MPZ or myelin P0 is the most abundant protein in the myelin sheath of peripheral nerves. And when I speak with individuals who have CMT who may not have a scientific background, I always think of a peripheral nerve like an electric wire. There's an inner copper wiring that we call the axon, and you may have heard of axonal neuropathy. And then there's an outer insulation called the myelin sheath. And the myelin sheath is really important because the way nerves work is they conduct little electrical signals down the nerve to stimulate your muscles or to allow one to perceive different sensations. And so shown to the right is work from Dr. Michael Shai, who has done a lot of the work in CMT from MPZ mutations. And not sure that I have a pointer here, but basically what you can see to the right is that the MPZ protein is a very complex protein that inserts itself in the myelin sheath. And in the panel below, there are a lot of different proteins that are part of what Dr. Moss referred to as compact myelin. And so the myelin P0 or P0 interacts with some of the other proteins like PMP22. And so you can imagine that if there's a mutation in a gene in the MPZ gene, that's going to lead to an abnormal myelin P0 protein. And because the MPZ is so important in compaction of myelin, an abnormal myelin P0 protein will lead to an abnormal myelin sheath, which can lead to neuropathy. In addition, when you have gene mutations in myelin P0, the abnormal protein can get trapped in an organelle in the cell that we call the endoplasmic reticulum. And when this abnormal MPZ or myelin P0 gets trapped in the cell, it can lead to stress in what we call the Schwann cells that make myelin, and also activation of a process known as the unfolded protein response. And so between an abnormal myelin sheath and this abnormal trapping of abnormal myelin P0 protein, that can lead to the manifestations in CMT, and that's where future treatments may be targeted to. So one thing that's really challenging with CMT due to MPZ mutations is, unlike PMP22, where there's just one genetic abnormality, which is an extra copy of the PMP22, in myelin P0 CMT, there are lots of different variations in the DNA in the gene that can lead to CMT. Over 200 different mutations in the MPZ gene have been identified. And these different MPZ variants lead to different ages of onset, different nerve conduction abnormalities, different severity of CMT. And that is really well captured on this research from Dr. Shai. And if you look at this graphic, on the horizontal axis is your conduction velocity, how fast your nerves are conducting between 0 or less than 10 meters per second, all the way up to 60 meters per second. And on the vertical axis is the age of onset of the CMT. So the individuals who are represented by the blue dots in the lower left-hand corner are individuals who had onset of their CMT in the first years of life and have very slow nerve conduction studies, 10 meters per second. And there's certain of the MPZ genetic variants lead to individuals with very severe early onset CMT. But for the individuals who are represented by the red squares, they have different variants in MPZ, and there the age of onset is in adulthood, and the conduction velocities are much faster. So different MPZ variants lead to very different CMT manifestations. And we use different names to describe these. If your onset of CMT was in the first year or two of life, we call it congenital hypomyelinating neuropathy or Dejeron-Sota syndrome. And many of you may have heard of that. If you have a more typical CMT presentation with demyelination, we call it CMT1B. But if you have an adult onset form of symptoms with normal conduction velocities, we call it CMT2. So very different names, but all can be due to mutations in MPZ. And I'm not going to spend too much time on the symptoms because the symptoms mirror very much the symptoms that we know from CMT. Foot drop, problems with hand weakness, balance, Problems with walking could be mild tripping or requirement for braces, but individuals who have that very early onset form of MPZ CMT often have very delayed walking, may need a walker or wheelchair in a high proportion. Sensory loss, pain, muscle cramps, fatigue, restless leg syndrome. Very severe forms of MyLMP0 CMT might have respiratory issues or severe scoliosis. And one feature of CMT from MPZ mutations that's not seen with all CMT is cough. There's some individuals who have MPZ mutations who get recurrent, unexplained severe coughing fits and have this lifelong, and it runs in families. And there's certain mutations in the MPZ that are more adult onset forms where episodic cough is a major feature. There can be problems with sleep, and this can all lead, of course, to varying difficulties, impairments of quality of life. So what about, where is the research? Well, there are a number of research avenues. There's been research on curcumin, and many of you may have heard of curcumin, but in a number of studies, curcumin is just a component of the turmeric spice. And curcumin is very insoluble. And if we take curcumin, it's available over the counter. It's not absorbed well. But if you dissolve it in sesame oil, or you have a phosphatidylcholine curcumin, it has better absorption and has been shown to improve neuropathy in severe forms of MPZ CMT. And it does this by reducing cell stress that we talked about. It improves myelin in the mice and physical function. And one of the cautions, don't go out and buy curcumin, because first, if you have MPZ mutations, first of all, curcumin that you might get is not well absorbed. And second of all, it can have significant side effects if used in too large amounts in the wrong individual. But certainly curcumin is one of the compounds that may be worthwhile studying in a future clinical trial. There's another designer compound that is very pertinent for MyLMP0 forms of CMT called IFB088 or CEFN1. And it was specifically designed to address that cell stress that is caused by the retention of the MyLMP0 and the endoplasmic reticulum and the activation of unfolded protein response. And in a paper that was just out this year, in an animal model, a mouse model, it was shown to improve the grip strength of mice, improve their holding time on a bar, and also to improve the thickness of myelin. And so this is a compound that there's a lot of interest in. Hopefully one day, there being clinical trials, specifically in individuals who have CMT with MPZ mutations. And then finally, what about gene therapy for CMT due to MPZ mutations? Well, the field is further behind than some of the other forms of CMT for the very reason that there are 200 different mutations to target. And how do you actually target those 200 mutations? Because you can't develop a designer gene therapy for each one of those variants individually. Well, the CMTRF in a press announcement earlier this summer has a grant that they gave to Dr. Rashnanajad at Ohio State to do just that, develop genetic therapy for CMT1B. And what's the principle? We all know about the power of mRNA now from our COVID vaccines, but this is leveraging little bits of mRNA or RNA in different ways. So here, Dr. Rashanajad is going to take something called a microRNA and use that to actually silence the abnormal copy of the MPZ gene. So RNA is used to make, it provides the message to build the protein. And if you block that RNA from making the protein, you can eliminate the bad effects of the abnormal protein. And then the plan is to put it in certain RNA, a healthy copy, to allow cells to make a normal MPZ protein. And the hope is to do that in such a way that it doesn't matter what MPZ variant you have, that for the majority, you could silence the abnormal gene and replace it with a healthy copy to potentially improve the outcome for CMT. So my very last slide, basically, I talked a bit earlier before I triggered the fire alert that what about getting ready for clinical trials in MPZ? So if you are a patient who has CMT with an MPZ mutation or CMT1B, you can participate. There are ongoing studies in children and adults looking at determining the best ways to design clinical trials. Various universities, including ours at University of Rochester, participating in these. We're looking at what are the best clinical scales. We're looking at those wearable sensors of gait and balance in children and adults. And we're looking at various of these imaging biomarkers, muscle MRI, and then at University of Rochester, nerve and muscle ultrasound, and looking at these little sensory nerve endings called Meissner corpuscles. We're looking at plasma samples for plasma biomarkers, and in some individuals, skin biopsies to look at biomarkers. So I'll stop there. And I think Dr. Moss and I will be happy to answer any questions. They might have questions online as well.
Yes, they are.
Yes. I'll ask a question, but good. So our family has 1A. Actually, you can come up to the microphone. Oh, sure. Yeah. Yeah, we just, sorry, for this session, we're kind of short staffed. Thanks, sir. So our family has 1A, and my dad had it. I have it. My daughter Sarah has it. And it's interesting to hear you talk about the sort of 50-50 proposition if you have a healthy, one healthy parent and one that's affected with the disease. Yet in our family, everybody has it. Is that just like the luck of the draw? Like it's still 50-50, but it's just the luck of the draw that all my nieces and nephews and brothers and sisters have it?
Yes. My family's the same way. So I have 2 siblings and we all have it. And then my grandmother was one of 9. I don't know the exact odds, but it's definitely more than 50%. Should we get a genetic perspective on this? But it's 50% chance each child individually.
Yeah. Yeah, we hit a home run, huh? It just is what it is. So let me ask you another related sort of question. In our family, many of these people also were born with 1 kidney. My daughter, myself, or my niece, is this like 1 kidney thing going on in our family. And I'm aware of other CMT patients where there's a solitary kidney as well. And I'm just curious whether there could be some connection there. I don't know.
I think we had 3 CMT people around a table,
We did.
right?
That's it. I didn't want to
That
give
had 1
names,
kidney.
but we did. Yeah. Yeah, it was very strange. And nobody's done any research on it, I suspect. Okay, we should talk because it just feels to me like there's some connection. So anyways, that's it.
Yeah, I haven't experienced that personally and I don't know much about it, but I'm sure they're better experts to talk to.
Okay, thank you.
You able to pick up on it or not?
I have a question.
Any other questions
Yes.
online?
Can you hear
Did
me?
the online ones just come in?
Yes.
Yes, this is the Priest family?
We have 3 people.
Are all PMP22 duplications created equally?
No. So we talk about it like it's 1 duplication, but there are definitely variations. And there's another disease that we consider CMT type 1E, which is PMP22 point mutations generally, but it's not just point mutations. So similar to how Dr. Herrmann talked about CMT1B and actually calling MPZ related disease, I think there's a broader perspective of something going on with PMP22. And there's all sorts of different mutations that affect PMP22 and cause disease. And so the phenotypes of HMPP are different than CMT1A. HMPP is often more mild and affects the myelin as shown in patient nerves differently. And so sometimes those mutations lead to more of an HMPP type symptoms as opposed to CMT1A symptoms. And that kind of gives you clues about how it's affecting the protein or the expression of the protein. For example, if it's just messing up the protein and leading to loss of function, that's going to resemble an HMPP type symptoms. Does that make sense? So yeah, there's lots of variation, to be honest. And I think they're more rare, so they don't get discussed as much.
I have a question.
Thank you. On that note of mutation, when you guys are conducting studies and some of these family history studies, because in our family, there is kind of that wide range of symptoms where there are some people who seem to have the exact same symptoms, but then there are others where it manifests differently. When you're doing some of these studies, is that taken into consideration? Like, I'm kind of curious how those patient to patient, I don't know, like how that actually gets captured in some of these studies when the focus is usually on clinical care of one individual, and privacy concerns could probably also prevent some of these broader comparisons. And so I'm just curious how that's dealt with in your field.
Yeah. So. Yes, so that's an outstanding question, and you're asking about I believe, the variability of severity of CMT in families, because across CMTs, CMT1A,
Okay.
MPZs, CMTs, we do see some family members who have onset of symptoms much earlier, more affected, and others who very mildly affected. And certainly with CMT1A, we see individuals who go through life and never realize they actually have it when they actually carry the gene. So there's a lot of research that's going on to look at what we call genetic modifiers. Dr. Zuckner is who has led a lot of that research and found a few genes where variations in the genes that by themselves don't cause CMT, but they can either lessen or worsen the effects of the disease. So there's a lot of research going on for looking at genetic modifiers. But it's a challenge because for genetic modifier studies, you ideally need thousands of individuals. Easier for CMT1A, harder for MPZ. And you get to a very challenging point is when I see patients, and we have a very large CMT clinic in Rochester, I'm often just seeing one patient in a family. And then the information I get about the other family members is very limited. Maybe someone else comes to a clinic visit and we can get a little bit of information, but for privacy reasons, unless they also enroll in research and commit to that time, we can't capture all these assessments from them. And then there are relatives who live 3 states over or in Canada. And so I think we are losing a lot of power again, to the discussion with Dr. Pat Livney this morning on genetics and just capturing everyone who's got CMT and having them engaged in research. We're losing power because we're not able at scale to really study all the family members. Occasionally that happens, but it's a challenge, and how to make that happen, we haven't quite figured out yet.
Sorry, so I'll follow up just asking, like, if we have, if the people who are participating in this conference are kind of motivated individuals within a larger family, what are things that we as individuals can do? It sounds to me like it's more than enrolling in a study. It's more as in trying to direct everyone to a single clinic or clinician, or is there cooperation across clinics that would be, because our family is very dispersed?
Yeah. So at least, in the United States, it's not as coordinated as it could be, but within the Inherited Neuropathies Consortium, there are, 15, 18 centers in the United States. And so potentially, if your family were to reach out to a center within our Inherited Neuropathies Consortium and wanted to participate in natural history studies or gene modifier studies or whatever the case might be, you could have some individuals evaluated at different centers. So some could come to Rochester, some could go to Penn, some could go to University of Miami, depending on where they are. So that is one avenue. The other avenue that we're starting to leverage is just remote evaluations. We can't do everything remotely, but there are ways now and protocols where we can get informed consent, do a study visit remotely via Zoom and capture some information. We could do questionnaires over Zoom, some functional assessments. Dr. Shai has developed something called the virtual CMT exam score. It's not as rigorous as doing it in person, but it's still very useful. And then Dr. Zuckner said that we can send kits to families for testing. So ideally, for the whole genome studies, blood samples are better. But, you know, we do a lot of sending out saliva kits, both for clinical diagnosis. And we do this a lot now in the clinic. When patients come to us now more and more, we're actually having other family members, and they're not even engaged in research, wanting other people to get tested. So we're finding ways to do testing of siblings and parents. And we sometimes need to do that to determine actually whether a particular gene is causing the disease. So there are ways. I think the first point is just engage with one of the centers and start having that conversation.
Oh, God.
I can follow up on that. When I was either in high school or college, I don't remember. I grew up in Michigan and Dr. Shai was in Detroit at the time. And I don't know how the whole process happened, but my grandmother had Dr. Shai and some colleagues out to her house one day, and they enrolled us in a study. They took blood, they did simple nerve conductions, they did the neuropathy score on us. So perhaps you could set something up like that. If you do like a family reunion and get everyone in the same place, you could potentially get some researchers interested in coming out and doing some studies.
Hi, everyone. This is Susan. Can you guys hear me in the room?
Yeah.
Okay,
Yes.
great.
Yes, we can.
Great. I know I was listening and I heard that Mr. and Mrs. Priest had a question, and I want to invite them to speak now if you're still online.
Yeah, we're still here. You hear us?
We sure can.
Yes.
Okay, our family has 3 individuals with CMT, the mother and 2 sons who are both close to 50 years old. They've also, all 3 of them, been diagnosed with mitochondrial ATP6 deviations. Can you provide any insight as to that?
Yeah. So mitochondrial ATP6 is a rare cause of CMT, but we do have some patients with that in our clinic at University of Rochester. And what we're learning is that there are many genes that are integral to mitochondria, which are the energy producing centers of nerve cells. And either primarily there can be mutations in mitochondrial genes, or secondarily there can be dysfunction or abnormality in how mitochondria are functioning or moving within nerves, and that can lead to CMT. So future treatments may target mitochondria. As far as mitochondria ATP6, a number of the patients we've seen with this have a lot of what we call ataxia. They get a lot of imbalance and sensory involvement. And then they can also have episodes of weakness. So we actually reported on some families where they would get the CMT and then they would have episodic, what we call periodic paralysis, where they would have these episodes of weakness that would last for some hours and resolve. But right now, I think that, that's an area where I think more studies needed, along with other rare forms of CMT, to collectively actually come up with treatments that are directed at some of the mitochondrial forms of CMT.
Our son does have ataxia, unbalance, and weakness as well.
And he's treated with citazolamide for the periodic weakness.
Yeah, so citazolamide does help, at least in our experience, some of the episodic weakness, but it doesn't impact the progression of the underlying CMT, but it can help with some of the episodes of weakness that patients with this have.
Do we have one more question online? And then
There's one that was typed in, Cleary, and it's, I have CMT1B and would like to know if a low resting pulse around 40 is related with CMT1B. And it's funny because another person said she wanted to hear the answer to that question as well.
So I am not familiar with at least in the population of patients I treat with CMT1B with bradycardia. But it's important to realize that your heart rate is controlled by the autonomic nervous system. And there are some patients with certain types of CMT1B that do have some autonomic abnormalities, depending on your type of mutation. Some individuals have abnormal pupils. So they may have abnormal reactivity of the pupils in that. So I'm not aware in those patients of a slow resting pulse, but I don't think, I think it's always important as a patient to make sure that your physician has ruled out common causes for having a slow resting pulse, because we don't want to attribute rare manifestations to CMT. But once a common causes and all other causes have been excluded, there is that possibility that the autonomic nervous system could be affected.
I have two children and they don't demonstrate any of the physical properties like I have. Would it's like catching that it could be of merit to have their blood tested or not?
Sorry, say that it could it be what?
Would it have any merit to have their blood tested? I mean,
So I can tell you when when Dr. Shai came out and tested some of my family members and then made diagnoses by a simple electrophysiology in hands. Some people who didn't have or who didn't think they had CMT were diagnosed as positive. So it's possible they have it and it's very mild, but do you want to comment further?
Yeah. So this question comes up a fair amount when we see patients in a CMT clinic, because you have a family member and they say, well, what about our children? And I think there are a few things, I don't know what type of CMT you have, but CMT can be onset at different ages. So if you have someone who's perhaps 65 and their first symptoms were at 45, but their children are 28 now, they may not have yet manifested. And so I think the way we do this is that, if people don't have symptoms, I think it's some families and children just do not want to explore further whether they are affected or have minimal manifestations that they're just not yet aware of. But for others, even although they may not have symptoms, they really are motivated to find out because they have children and those patients can be seen in clinic as well. So we often see family members who may not yet have symptoms, but we really leave it up to families and patients to decide at what point they actually get evaluated.
I'm basing mine on the fact that their ankles are about this big.
I see.
Yeah. One little follow-up. Do you foresee reversibility in the future?
You don't see. Well, so I think, this is I was seeing some signs that we're nearing the end of our time, but I think that, but the answer to it is, I think there is that possibility if you treat very early. So I think there are two goals of treatment. We want to try and find treatments for everyone. So depending on when you treat, the realistic goal is to try and slow or stop the CMT from getting worse. And for many patients who have very advanced CMT, where there's a lot of muscle atrophy, a lot of ankle weakness, it may not be realistic to give a therapy and have that strength return, but we may be able to stop people from getting worse. But the hope is that if you treat earlier in the disease, children or earlier, before that weakness really develops, that you may be able to stop it from ever developing or result in some improvement.
Right. Thank you very much to Drs. Moss and Herrmann for both the presentations and answering our questions.